Hi, good morning, doctors. I'm Dr. Sesha, your study buddy for studying for MRCGP International AKT exam. Today is the 25th day of reading Oxford Handbook of General Practice, and we were reading at page number 488. Our topic for discussion today is musculoskeletal problems, rheumatoid, and chapter 11. Our current topic is rheumatoid arthritis. Let's start reading. Rheumatoid arthritis is the most common disorder of connective tissue affecting 1% of the UK population. It's an immunological disease triggered by the environmental factors in presence of in patients with genetic predisposition. Disease course is variable with exacerbations and remissions. Refer all suspected cases of rheumatoid arthritis to rheumatology. Early treatment with disease-modifying drugs can significantly alter the disease progression. Refer urgently if small joints of the hands and feet are affected. More than one joint is affected. There has been a delay of more than 3 months between onset of symptoms and seeking medical advice. So, the disease course is variable with exacerbations and remissions. That is why you have to refer all the suspected cases of rheumatoid arthritis to rheumatology for early treatment with DMARDS. So, small joints, when you see small joints of the hands and feet are affected, more than one joint is affected, or there has been delay more than 3 months between onset and seeking medical advice. Presentation can present at any age. Most common in the middle age. Female to male ratio is 3:1. Variable onset, often gradual, may be acute. Usually starts with symmetrical small joint involvement, that is pain, stiffness and swelling and functional loss, especially in the hands. Joint damage and deformity occur later. Irreversible damage occurs early if treated and can uh, cause deformity and joint instability. Other presentations: monoarthritis, migratory palindromic arthritis, PMR-like illness, and systemic illness of malaise, pain, and stiffness. Symptoms and signs: predominantly peripheral joints are affected, symmetrical joint pain, effusion, soft tissue swelling, early morning stiffness. Symptoms and signs: peripheral progression to joint destruction and deformity. Tendons may rupture. Specific features are listed in table 14.8. Differential diagnosis of rheumatoid arthritis. Diagnosis may not be easy. Consider psoriatic arthritis, nodal osteoarthritis, SLE, especially in females less than 50 years, bilateral carpal tunnel syndrome, other connective tissue disorders, polymyalgia rheumatica if more than 50 years. Investigations: check the FBCs, full blood counts. There will be a normochromic normocytic or hypochromic microcytic anemia. ESR and CRP are raised, may have raised platelets and decrease in WCC count. Rheumatoid factor and anti-CCB antibodies are positive in majority, and minority have a positive ANA titer. X-rays. X-rays are normal. Periarticular osteoporosis or soft tissue swelling in the early stages. Later, loss of joint space, erosions, and joint destruction. Management. A multidisciplinary team approach is ideal. A GP, medical and surgical teams, physiotherapist, podiatrist, OT nurse specialist, and social worker. Screening for depression 173. General support. Provision of information about the disease treatments and support available, including equipment, help with everyday activities and self-help and carers group, disabled parking badges and financial support. Physical therapy. Exercises, splints, appliances, strapping help to keep the joints mobile. Decrease in pain and preservation of function. Specific features of rheumatoid arthritis. Hands. Specific features of rheumatoid arthritis about the hands: ulnar deviation of the fingers, Z deformity of the thumb, swan neck deformity, that is hyperextended proximal interphalangeal joint, and flexed DIP joints, and Boutonniere's deformity, flexed PIP joints, and extended MCP joints, and extended MCP joints, hyperextended DIP joints. So, two types of deformity, swan neck deformity and Boutonniere's deformity of the fingers. Decrease in grip strength and decrease in hand function causes disability. Legs and feet. Subluxation of the metatarsal heads in the feet and claw toes. Pain on walking, Baker cyst at the knee may rupture mimicking DVT. Spine, especially the cervical spine, causing neck pain, cervical subluxation and alento-axial instability leading to a risk of cord compression. X-rays are required prior to general anesthesia. So in rheumatoid arthritis, first you have to do an X-ray of the spine because because there can be a cervical subluxation or alento-axial instability leading to risk of cord compression. X-rays are required prior to general anesthesia. Non-articular features. Common. Weight loss, fever and malaise, rheumatoid nodules, especially on the extensor surfaces of the forearms, vasculitis, digital infarction, skin ulcers, mononeuritis, eye problems like Sjogren's syndrome, episcleritis and scleritis, lungs, pleural effusions, fibrosing alveolitis and nodules. Heart problems, pericarditis, mitral valve disease, conduction defects, skin problems, palmar erythema, vasculitis, rashes. Neurological problems, nerve entrapment, example carpal tunnel syndrome, mononeuritis and peripheral neuropathy. Feltis syndrome, a combination of rheumatoid arthritis, splenomegaly and leukopenia, occurs in patients with long-standing rheumatoid arthritis. Recurrent infections are common. Hypersplenism leading to anemia and thrombocytopenia associated with lymphadenopathy, pigmentation and persistent skin ulcers. Splenectomy may improve the neutropenia. So, Feltis syndrome is a combination of rheumatoid arthritis and splenomegaly and leukopenia. This is the triad of Feltis syndrome. C-reactive protein is an acute phase reactant is an acute phase protein that increases less than 6 hours after an acute event, follows clinical state more rapidly than ESR, not increased by SLE, leukemia, ulcerative colitis, pregnancy, osteoarthritis, anemia, polycythemia or heart failure. Highest levels are seen in bacterial infections, that is more than 10 milligrams per liter. So Boutonniere's deformity. There are two deformities in rheumatoid arthritis in the fingers. Boutonniere's deformity and spine neck deformity. Boutonniere's deformity is hyperextension at the metacarpophalangeal joint, flexion at the proximal interphalangeal joint, and extension at the distal interphalangeal joint. This is the Boutonniere's deformity. And Schwann neck deformity is extension at the proximal interphalangeal joints and flexion at the distal interphalangeal joints. This is the Boutonniere's deformity. Musculoskeletal problems, 490 medication. NSAIDs and simple analysis. Excuse me. Example, regular paracetamol provides symptomatic relief but does not alter the course of disease. Patient's response to NSAIDs is individual. Start with the least gastric toxic, that is ibuprofen, 200 to 400 milligrams TDS, and alter as necessary. Example, to naproxen 500 milligrams BD. If the patient has a history of indigestion or gastric problems, consider adding a gastroprotection, example PPIs. Or if there is no history of CVD, using a COX-2 inhibitor, add a celecoxib 100 milligrams BD. Corticosteroids. Intra-articular injections of steroids, example triamcinolone, can settle the localized flares, example knee or shoulder flare, and can be used up to 3 times in a year in any particular joint. Depot injections, IM injections, or IV infusions, pulses can also help settle an acute flare but offer short-term benefits with the risk of systemic side effects. Daily low-dose oral steroids may help symptoms, and there is some evidence that they can modify disease progression, but concerns about adverse side effects have limited use. Disease-modifying drugs. DMARDs, methotrexate, sulfasalazine, penicillamine, biological therapies, rituximab, infliximab, etanercept, adalimumab, gold, azathioprine, hydroxychloroquine, cyclosporin, cyclophosphamide. Only under consultant supervision, decreases the disease progression by modifying the immune response and inflammation. Used individually or in combination, they are now started very early in the disease, in the first 3 to 6 months. Hence, the need for early referral. DMARDs can now take several months to show any effect. Before starting, check a baseline urea electrolytes, creatinine, EGFR, LFTs, FBCs, and urine analysis. Side effects and monitoring, table 14.9. Results can requiring action. If a total WBC count is less than 33.5, if the neutrophils is less than 2, if there is persistent proteinuria, that is more than 1 plus on 2 samples, or hematuria, platelets less than 150, LFTs ALT by AST ratio more than 2 times the baseline. Discuss with the rheumatologist and then either stop the medication. Surgery aims to relieve pain and improve function. Consideration of risk and benefits and most appropriate timing of surgery is vital. Common procedures include joint fusion, replacement, excision, tendon transfer and repair, and nerve decompression, depending on the joint that is affected. Complications of rheumatoid arthritis: physical disability, depression, osteoporosis, increased infections, lymphoma, cardiovascular disease, amyloidosis, 10% of the cases. Side effects of treatment. Further information is given in the following links. So table 4.9, specific disease modifying drugs and side effects and monitoring. Drug, that is methotrexate. Methotrexate is usually given in a dose of 7.5 to 25 milligrams weekly. It is common practice to give a folate 5 milligrams a day after the methotrexate. So this was also asked. It's a common practice to give folic acid 5 milligram the day after methotrexate, that is weekly as well. So routine monitoring. You need to check the full blood count, urea electrolytes, EGFR, LFT weekly until the dose and monitoring are stable, then monthly for at least 1 year. Frequency of monitoring may be decreased by specialists if disease or dose stable after 1 year. Chest X-ray within 1 year of start of treatment. Check the baseline lung function if lung disease is present. So, if the rheumatoid arthritis is affecting the lungs, then check the baseline lung function and then chest X-ray within 1 year of starting treatment. Side effects to monitor. Ask for reporting symptoms or signs of infection, especially a sore throat should be reported. If severe respiratory symptoms are present less than 6 months after starting, refer to accidents and emergencies. If MCB count more than 105, check with vitamin B12 and folate levels. Advise patients not to self-medicate with aspirin or ibuprofen and avoid alcohol. when using methotrexate. Sulfasalazine 1 gram BD or TDS. Maintenance. So FBC, when you're giving sulfasalazine, you have to check full blood count and LFT monthly for the first 3 months, and then every 3 months. Urgent for full blood count if intercurrent illness during initiation, and if stable after a year, frequency of monitoring may be reduced by the specialist. So sulfasalazine, there is less frequent monitoring of FBC and LFT, that is monthly only. Before, for methotrexate, it is weekly for the first until the dose is stable, and then monthly. So sulfasalazine, the side effects are rash, 1% cases, nausea and diarrhea, often transient, bone marrow suppression in 1 to 2% in the first months. If the MCV is more than 105, check vitamin B12 and folate levels. Intramuscular gold or myocrysin, 50 milligrams monthly. If you need to check when you're giving gold, you need to check full blood count, urine analysis at the time of each injection, and chest x-ray only 1 year of starting of treatment. Ask patients to report symptoms and signs of infection, especially a sore throat, bleeding, bruising, breathlessness, cough, mouth ulcers, and metallic taste or rashes. Penicillamine, 500 to 750 milligrams per day maintenance. So when you're giving penicillamine, you need to check FBCs, urine analysis every 2 weeks for 3 months, and 1 week after any increase in dose, then monthly. So altered taste can be ignored, and there can be a rash. Azathioprine, 1.5 to 2.5 milligrams per kg per day maintenance. FBCs, LFTs weekly for 6 weeks, and then every 2 weeks until the dose monitoring stable for 6 weeks. So here also you have to have intensive monitoring. So every week for 6 weeks, and then every 2 weeks until dose is stable for 6 weeks. And then after that you can check it monthly. GI side effects, rash, bone marrow suppression. Avoid live vaccines when you're taking azathioprine. If allopurinol is co-prescribed, decrease the dose to 25% of the original dose. Cyclosporin, 1.25 milligrams per kg BD maintenance, and you need to check FBCs, LFTs monthly until the dose monitoring is stable for 3 months. Again, this is like the other drug, which was sulfasalazine. This is also monthly for 3 months. Cyclosporin, then every 3 months. Urea electrolytes, creatinine, EGFR every 2 weeks until the dose is stable for 3 months, and then monthly. Lipids every 6 months. So there is 3 types of monitoring here. FBCs, LFTs monthly, urea electrolytes and creatinine every 2 weeks. So that is more frequent. And then lipids 6 monthly. Rash, gum soreness, hirsutism. Cyclosporin is the cause of hirsutism. Renal failure and increased creatinine. If creatinine is increased by more than 30% from the baseline, withhold and discuss with the rheumatologist. So that is why you are checking urea electrolytes and creatinine EGFR every 2 weeks, because it will cause renal failure. So you have to check if creatinine is increased by more than 30% from the baseline, you need to withhold and discuss with rheumatologist. Blood pressure is raised, and so you need to monitor the BP. Hydroxychloroquine. A baseline eye check and an annual check of visual symptoms and visual acuity need to be done. Rash, GI effects, ocular side effects are rare. Leflunomide, 10 to 20 milligrams per day maintenance. FBCs, LFTs monthly for 6 months, and then if stable every 2 months. So leflunomide is good because FBCs and LFTs monthly you have to check for 6 months, and then if stable every 2 months you have to check. It's maintenance. Rash, GI effects in high BP, high ALT, so it's affecting the liver enzymes. Check the weight and BP at each review. Before starting, check the baseline urea electrolytes, creatinine, eGFR, LFT, FBC and urine analysis. I think this is for allopurinol. So whenever you are prescribing allopurinol along with azathioprine, you need to check. First of all, reduce the dose of allopurinol azathioprine to 25%, and then before starting, check the baseline urea electrolytes, creatinine, eGFR, LFTs, FBCs and urine analysis. Musculoskeletal problems 492. The spondyloarthropathies. These are a group of inflammatory rheumatic diseases characterized by predominant involvement of the axial and peripheral joints, entheses, areas where the tendons and ligaments or joint capsules attached to the bone, includes ankylosing spondylitis, psoriatic arthritis, reactive arthritis, Rita's syndrome, Behcet's disease, arthritis that accompanies inflammatory bowel disease, and Whipple's disease. Sacroiliitis and spondylitis occur with all of them, and they are associated with HLA-B27 genotype. So all of these arthritis, spondyloarthropathies have sacroiliitis and spondylitis, and they are associated with HLA-B27 genotype. Ankylosing spondylitis. Prevalence in 1 in 2000. Males to female ratio is 2.5:1. 95% HLA-B27 positive. Prevalence in population mirrors the frequency of HLA-B27 genotype. Risk of developing ankylosing spondylitis if HLA-B27 is positive is 1 in 3. So presentation typically present with morning back pain or stiffness in a young man. Progressive spinal fusion ankylosis leads to decrease in spinal movement, spinal kyphosis, sacroiliac joint fusion, neck hyperextension and neck rotation. Other features are there is decrease in chest expansion, chest pain, hip and knee arthritis, plantar fasciitis and other enthesopathies, iritis, Crohn's or ulcerative colitis, heart disease, carditis, aortic regurgitation, conduction defects, osteoporosis and psoriasiform rashes. So these are the other features of ankylosing spondylitis. First one would be these are the orthopedic features, and then these are the other features. So tests. Full blood count. Normochromic or microcytic hyperchromic anemia. Increased in ESR may be normal. Rheumatoid factor is usually negative. So these are seronegative arthritis. So rheumatoid factor will be usually negative. X-rays show initial signs of widening of the SI joints and marginal sclerosis, later SI joint fusion and a bamboo spine, vertebral squaring and fusion can be seen. Management aims to decrease the inflammation, pain and stiffness, alleviate the systemic symptoms, example fatigue, and slow or stop the long-term progression of the disease. Exercise helps in back pain. NSAIDs, naproxen, 500 mg BD also help in pain. Refer to a rheumatologist early for confirmation of diagnosis and education and disease-modifying drugs, and advice on appropriate exercise regimens to maintain mobility. So what are the extra-articular features of ankylosing spondylitis? Decrease in chest expansion, chest pain, hip and knee arthritis, plantar fasciitis and other enthesopathies, iritis, Crohn's or ulcerative colitis association, heart disease, carditis, aortic regurgitation and conduction defects, osteoporosis and psoriasiform rashes. Psoriatic arthritis is an inflammatory arthritis associated with psoriasis. 40% psoriasis patients, females and male equal ratio. 75% patients have a pre-existing history of psoriasis before the arthropathy. In 50%, a rash appears simultaneously with joint symptoms. In 10%, arthritis precedes the skin changes. Presentation is variable. Patterns include distal arthritis, DIP joint swelling of the hands and feet, nail dystrophy, plus flexion deformity. Sausage-shaped fingers are characteristics of psoriatic arthritis affecting the hands. Rheumatoid-like polyarthropathy. Similar to Rheumatoid arthritis, but less symmetrical, and rheumatoid factor is negative. Mutilans, arthritis mutilans associated with severe psoriasis, erosions on small bones of the hands and feet plus spine, bones dissolve, leading to progressive deformity. Ankylosing spondylitis or sacroiliitis, usually HLA-B27 positive. Investigations. WBC usually high, ESR-CRP usually high, rheumatoid factor is negative, and X-ray appearance can be diagnostic of psoriatic arthropathy. Management. Education, physiotherapy, NSAIDs. Refer to rheumatology for confirmation of diagnosis. Advice on management and disease-modifying drugs. Medications are methotrexate may improve both skin and musculoskeletal problems in psoriatic arthritis. Reactive arthritis. Often a symmetrical aseptic arthritis in more than one joint occurs 2 to 6 weeks after a bacterial infection elsewhere, like gastroenteritis due to Salmonella or Campylobacter, genitourinary infection due to chlamydia or gonorrhea. So both chlamydia, gonorrhea infection or Salmonella, Campylobacter, gastroenteritis can cause reactive arthritis and increase incidence in HLA-B27 positive individuals. Management. NSAIDs, physiotherapy, steroid joint injections. Recovery usually occurs within months. A minority develop chronic arthritis requiring DMARDs. Refer to rheumatology. Reters syndrome, polyarthropathy, urethritis, iritis, psoriasiform rash. So, iritis, urethritis, and psoriasiform rash and polyarthropathy affecting men with HLA-B27 genotype commonly follows genitourinary or bowel infection. Joint and eye changes are often severe. Refer for specialist management. So the difference between reactive arthritis and Ritter syndrome is, in Ritter syndrome there is urethritis and iritis also and a rash, whereas there in reactive arthritis only there is aseptic arthritis. Ritter syndrome additionally have eye and urethral involvement. Behçet's disease is a multi-organ disease of unknown cause, although thought to be infective. Male to female ratio is 2:1. The clinical picture, only some features, arthritis, ocular symptoms and signs, that is pain, decrease in vision, floaters, iritis, scarring, painful ulceration of the mouth and scrotum, colitis, meningoencephalitis. Refer to the gum clinic, ophthalmologist and general physician depending on the symptom cluster. Treatment is usually with steroids plus azathioprine or cyclosporin. Topical steroids may be useful for ulcers. So in Behçet's disease, there will be arthritis will be there, plus ocular symptoms and other signs of pain, reduction of vision, floaters, iritis, scarring, painful ulceration of the mouth or the scrotum, and colitis and meningoencephalitis. So when you have this genital symptoms, send to gum clinic, refer to gum clinic. If iritis is present or floaters are present, refer to an ophthalmologist and general physician depending upon the symptom cluster. So treatment is with steroids and azathioprine or cyclosporin, and topical steroids may be useful for ulcers. Enteropathic spondyloarthropathy, oligoarticular or polyarticular arthritis linked to inflammatory bowel disease. A presentation is variable and includes sacroiliitis, plantar fasciitis, inflammatory spinal pains and other enthesitis. Insertional ligament or tendon inflammation. Arthritis may evolve and relapse or remit independently of bowel disease. So the arthritis in inflammatory bowel disease is independent of the disease activity. Management. NSAIDs may help joint pains but aggravate bowel disease in case of inflammatory bowel disease. enteropathic spondyloarthropathy. So refer to rheumatology for confirmation of diagnosis and advise management and disease modifying drugs. Crystal induced arthritis. Hyperuricemia. Increase in serum uric acid causes are drugs, cytotoxic drugs, diuretics, ethambutol. Increase in cell turnover like lymphoma, leukemia, psoriasis, hemolysis. Decrease in excretion, primary gout, CKD, hyperparathyroidism. Disorders of purine synthesis, Lesch-Nyhan syndrome. So causes the gout. Gout is intermittent attacks of acute joint pain due to deposition of uric acid crystals. Prevalence is 3 in 8 per thousand. Increases with age. That is, male to female ratio is 5:1. And risk factors are family history, obesity, alcohol excess, high purine diet, acute infection, surgery, CKD, plaque psoriasis, polycythemia, leukemia, diuretics, cytotoxics. Untreated gout is associated with increased risk of death from cardiovascular disease and chronic kidney disease. Presentation. Acute gout. Painful swollen joint, distal joints, example the big toe, the feet and the ankles most commonly. Red skin which may peel, plus or minus fever, can be polyarticular especially in elderly males, elderly females, may mimic septic arthritis. Chronic gout. Recurrent attacks trophy, urate deposits in the pinna and tendons and joints and joint damage. Okay. Investigation. Usually with clinical diagnosis, if investigations are required, consider blood, raised WCC, ESR, or normal or raised uric acid. Microscopy of synovial fluid, serum sodium monourate crystals on polarized light microscopy, X-ray, soft tissue swelling unless severe when disease erosive pattern is seen. Management of gout, figure 14.8, refer to rheumatology if serum urate cannot be controlled with drugs available in primary care or if symptoms are not settled despite treatment. Calcium pyrophosphate deposition disease or CPPD or pseudogout. Also, inflammatory arthritis due to deposition of pyrophosphate crystals or associated with osteoarthritis, hyperparathyroidism or hemochromatosis. Attacks are less severe than gout and may be difficult to differentiate from other types of arthritis. Knee, wrist and shoulder are most commonly affected. Acute attacks can be triggered by intercurrent illness. Okay. Chondrocalcinosis may be seen on X-ray, calcification of the articular cartilage, presence of joint crystals confirm diagnosis. Management. Treat the acute attacks like acute gout. A chronic form also occurs, frequently erosive. Refer to rheumatology for confirmation of diagnosis and advice on management and disease modifying drugs. So most of these diseases which are rheumatoid or rheumatoid factor positive or non-rheumatoid factor positive and spondyloarthropathies, most of these you have to refer to a rheumatologist for consideration of disease modifying drugs. Septic arthritis. The most important differential diagnosis for acute gout is most common in children less than 5 years old and more commonly affects the hip joint or the knee joint, but septic arthritis can occur at any age and affect any joint. Okay, so septic arthritis is more common in less than 5 years old and affects the hip joint or knee joint. The patient usually systemically unwell and holds the affected joint completely still. The joint may be swollen, hot and tender. It's an orthopedic emergency. If you suspect, you need to admit, and the treatment is with IV antibiotics and surgical washout of the joint. So this one is a flow chart for managing gout. Management of gout. Let's see the flow chart. When there's an acute attack, Patient comes to you with an acute attack of gout. Treat as early as possible. Patient education about gout. Rest, elevation and ice. So rice. Then NSAIDs or coxips plus PPI or colchicine 500 micrograms BD or QDS or corticosteroid intraarticular, intramuscular or per oral. So these are the three options of treatment. You can either give an NSAID plus PPI, or you can give a colchicine 500 micrograms BD or QDS, or you can give a corticosteroid during an acute attack. Review after 4 to 6 weeks. Assess the lifestyle factors, optimize the weight, diet, give a low purine diet as in table 14.10. We will discuss decrease the alcohol intake to less than 14 units per week, avoid the binges and decrease the sugary drinks and increase exercise. So these are the lifestyle advices. Assess the CVD risk factors like obesity, high BP, lipids and diabetes. You have to check everything and review prescribed medication. Stop diuretics if possible. So diuretics will cause increased secretion of uric acid. So decreased secretion of uric acid causing hyperuricemia. That's why you have to stop diuretics if possible and check the serum uric acid plus EGFR levels. Discuss the urate lowering therapy. Start after a single episode of gout. So if you're having a gout episode, then you have to start a urate lowering therapy. So after all these checkups, then routine follow-up. Once serum urate level less than 300 micrograms per liter and attacks have ceased, decrease the urate lowering therapy to maintain serum urate at 300 to 360 micromoles per liter. Check serum urate annually to ensure a target range. Adjust the dose of urate lowering therapy if not in range. Check the renal function and CVD risk factors annually and treat as needed. Then after that, initiating a urate lowering therapy. Start with an allopurinol 50 to 100 milligrams per day. Increase the dose by 50 to 100 milligrams every 4 weeks depending on the serum urate level, maximum of 900 milligrams per day, aiming for a serum urate less than 300 micromoles per liter. So your target in case of hyperuricemia will be a serum urate level in the range of less than 300 micromoles per liter. To prevent gout flares during titration, consider prophylaxis with colchicine 500 micrograms OD or BD or NSAID plus PPI. If allopurinol is not tolerated or unable to reach the target urate with allopurinol, switch to febuxostat. So allopurinol is the first line, and then if we are not able to reach the target urate levels with allopurinol, then you need to switch to febuxostat 80 or 120 milligrams per day. Consider sulfenpyrazone in addition instead if the target serum urate is not reached within first or second line drugs. The third line is sulfenpyrazone. Do not stop urate lowering therapy during an acute attack of gout. So adjust the drug doses if renal impairment is present. So after starting a urate lowering therapy, again there will be a routine follow-up and serum urate level should be less than 300 micrograms. An attack should have ceased. Then you have to reduce the urate lowering therapy to maintain serum urate level at 300 to 360. Management of gout. That was the flow chart. And next, purine content of common foods. So high purine foods, moderate purine foods and low purine foods. So high purine foods are oily fish like mackerel, herring, sardines, trout and whitebait. Seafood. Example, lobster, crab, prawns, mussels, fish, roe, caviar. Game, venison, pheasant, rabbit. Meat or yeast extracts. Example, beer, marmite and bovril. Offal, example, liver, kidneys, heart and sweetbreads. Liver, kidney, heart and sweetbreads. So these are organ meat and sweetbreads. These are all high purine content foods. Moderate purine content foods, most of the meat like beef, pork, lamb, most poultry, chicken, turkey, mushrooms, curon, processed legumes, example baked beans, kidney beans, soya products, some vegetables like asparagus, cauliflower, spinach, whole grains like bran and wholemeal bread. Low purine diet, dairy milk, dairy products, milk, cheese, butter, yogurt, eggs, bread, cereal, not whole grain, pasta, noodles, most fruit or vegetables. Connective tissue diseases. The group of overlapping diseases that affect many organs and are associated with fever, malaise, chronic, often relapsing remitting course, and response to steroids, often difficult to diagnose. Systemic lupus erythematosus is an autoimmune disease with prevalence 1 in 3000. Female to male ratio is more, 9:1. Raised in Afro-Caribbeans and Asians. Onset is 15 to 40 years. Presentation as in table. There must be a multisystem involvement in SLE. Investigations. Check for our autoimmune profile. 95% are ANA, anti-nuclear antibody positive. Other immunological abnormalities like increase in double dsDNA, rheumatoid factor positive, decrease in complement C3C4, and then FBC. There is reduced hemoglobin, reduced white cell count, and increase in ESR. Management. For SLE, refer to rheumatology. Use an NSAID for symptom control. Sunscreen protects the skin. ACBS. Steroids are mainstay of treatment of acute flares. Always discuss with a rheumatologist. Hydroxychloroquine can improve the skin and joint symptoms. So hydroxychloroquine can improve skin and joint symptoms in SLE. Cyclophosphamide, methotrexate, and cyclosporin are also used in SLE. Sulfonamides and hormonal contraceptives may worsen SLE. So these are the two drugs which may worsen SLE. Drug-induced lupus occurs with minocycline, isoniazid, hydrolazine, procainamide, chlorpromazine, sulfasalazine, losartan, and anticonvulsants. So drug-induced lupus causes can be minocycline, isoniazid is an antitubercular drug, hydrolazine is an antihypertensive, procainamide is antiarrhythmic, chlorpromazine, sulfasalazine is again a disease-modifying drug, and losartan and anticonvulsants. Remit slowly when the drug is stopped, but steroids may be needed. Discoid lupus erythematosus. It is a skin manifestation of SLE. Again, female to male ratio is 2:1. More than one well-defined red, round, oval plaques on the face, scalp, or hands. So it is a round or oval plaque, well-defined, red on the scalp, face, or hands. Scarring may be seen. Scalp alopecia, skin hyperpigmentation. Internal involvement is not a feature. Confirm with lesion biopsy. Investigate with an autoimmune profile as for SLE. Presentation of SLE. So this is the presentation. Symptoms are system, joints. 95% of the patients presenting complaints is arthritis, arthralgia, myalgia, and tenosynovitis. In the skin, 80%. Photosensitivity. A facial butterfly rash, vasculitic rash, hair loss, urticaria, and discoid lesions. Lungs, 50% of the patients. Pleurisy, pneumonitis, pleural effusion, and fibrosing alveolitis. Kidney, 50% of the patients. Proteinuria, high BP, glomerulonephritis, and renal failure. Heart, in 40% of the cases. Pericarditis, endocarditis. CNS, 15%. Depression, psychosis, infarction, fits, cranial nerve lesions. Blood, 95% patients. Anemia, very common, thrombocytopenia, and splenomegaly. Fatigue, 95% of the patients. SLE, treat with potent topical steroids or sunscreen. Remission occurs in 40%, 5% develop SLE. So this one was discoid lupus erythematosus. The treatment for discoid lupus erythematosus is topical steroids and a sunscreen, and remission occurs in 40% and 5% develop SLE. Antiphospholipid syndrome. Increase in clotting tendency occurs with SLE or alone, associated with thrombosis, stroke, migraine, miscarriage and myelitis, myocardial infarction and multi-infarct dementia. If suspected, start aspirin 150 milligrams OD and refer to rheumatology. So if you're suspecting an antiphospholipid antibody syndrome, then you start 150 milligrams aspirin and then you refer to rheumatology, may need anticoagulation. Sjogren's syndrome. Primary Sjogren's syndrome, under recognized cause of fatigue, dryness of the skin, mucous membranes, may present with dyspareunia. Often presents with nodal osteoarthritis, long-term associated with lymphoma. Autoimmune profile is characteristic of primary Sjogren's syndrome. So often primary Sjogren's presents with nodal osteoarthritis and dyspareunia, fatigue, dryness of the skin, dyspareunia and nodal osteoarthritis with autoimmune profile. Secondary Sjogren's syndrome in association with any of the connective tissue disorders like rheumatoid arthritis, keratoconjunctivitis sicca, decrease in lacrimation, dry eyes or xerostomia, salivation and dry mouth. Management. Refer to rheumatology, provide information or support, use artificial tears for dry eyes. Xerostomia may respond to frequent cool drinks, artificial saliva sprays, glandosane or sugar-free gum. Inform the dentist of the diagnosis. Rashes may respond to antimalarials. Raynaud's syndrome. Intermittent digital ischemia precipitated by cold or emotion, finger ache and changing color, pale blue red on rewarming, usually presents less than 25 years of age and is idiopathic, prevalence 3 to 20%, females more than males, often abates at menopause, 5% develop autoimmune rheumatic disease, mainly scleroderma and SLE. Differential diagnosis. Offer rheumatology other rheumatology conditions like scleroderma and SLE and rheumatoid arthritis. So whenever you are finding a patient with Raynaud's syndrome, you need to consider other diagnoses like scleroderma, SLE or rheumatoid arthritis, which may be associated with Raynaud's phenomenon. So hematology conditions like leukemia, polycythemia or thrombocytosis, cold agglutinins, monoclonal gammopathy and mixed cryoglobulinemia. Drugs like beta blockers, smoking, arteriosclerosis, thoracic outlet obstruction, trauma, use of vibrating tools. Management. Keep warm, socks, gloves, hats in cold weather, hand warmers, stay inside, avoid drugs that increase the symptoms like beta blockers, stop smoking. Nifedipine 10 to 20 mg CDS or amlodipine 5 mg OD or fluoxetine 20 mg unlicensed may help. In case of Raynaud's disease, if associated with severe symptoms, refer to rheumatology urgently if critical ischemia, example ulceration or infarcts on fingers. Systemic sclerosis is a spectrum of disorders causing fibrosis and skin tightening, scleroderma. Raynaud's phenomenon is usually present, positive, and there is increase in blood pressure, lung fibrosis, GI symptoms, telangiectasias, polyarthritis and myopathy. Provides educational support, treat the symptoms. Early specialist referral is vital for systemic sclerosis. Breast syndrome, that is calcinosis of the subcutaneous tissues, Raynaud's phenomenon, esophageal motility problems, sclerodactyly and telangiectasia, has a better prognosis. So the next topic is polymyalgia rheumatica and giant cell arteritis. Polymyalgia rheumatica or PMR and giant cell arteritis or temporal arteritis are two clinical syndromes that are part of the same spectrum. Key features are polymyalgia rheumatica and giant cell arteritis affect the elderly, rare, less than 50 years of age, affect the elderly and they are rare in less than 50 years, females more than males. 50% of patients with GCA also have PMR, also have polymyalgia rheumatica. 15% of PMR have GCA. Both conditions usually respond rapidly and dramatically to corticosteroids. So, they respond rapidly and dramatically to corticosteroids. Presentation. Diagnosis is clinical. Both PMR and GCA may present with malaise, anorexia, fever, night sweats, weight loss and depression. Check the ESR or CRP on presentation. Diagnosis of polymyalgia rheumatica. A person may be regarded as having PMR if following criteria are present. Age is more than 50. Duration more than 2 weeks. Bilateral shoulder or pelvic girdle aching. Your shoulder or the pelvic girdle is aching, that is axial skeleton. Morning stiffness during duration more than 45 minutes. Evidence of acute phase response, that is increase in ESR usually more than 30 or increase in CRP. Diagnosis can be made without increase in inflammatory markers if classic clinical picture and rapid response to steroid treatment is present. Diagnosis of giant cell arteritis. A person may be regarded as having a giant cell arteritis if three or more of the following criteria are met. Age is more than 50 years. There is a new onset headache that has developed within 2 weeks. Symptoms less than 2 weeks. Unilateral throbbing headache, facial pain, scalp tenderness. Example on brushing hair or jaw claudication. Increased likelihood of visual symptoms. Temporal artery abnormalities, tenderness, thickening or decrease in pulsation, raised ESR more than 50 millimeters per hour or raised CRP, abnormal temporal artery biopsy compatible with giant cell arteritis. So when you do a biopsy, it should be compatible with GCA. So if more than 3 of the following criteria are met, then you can diagnose as GCA. Visual symptoms of giant cell arteritis are amaurosis fugax, diplopia, sudden loss of vision, and early complications of GCA are maybe visual symptoms are an early complication of GCA and may be the presenting feature of giant cell arteritis. Differential diagnosis of polymyalgia rheumatica. Inflammatory arthritis like rheumatoid arthritis, connective tissue diseases, vasculitis, example SLE, osteoarthritis, septic arthritis, shoulder disease, neoplasia or myeloma, occult sepsis, endocarditis, inflammatory myopathies, fibromyalgia, endocrinopathy or metabolic bone diseases. GCA, giant cell arteritis, the differential diagnoses are herpes zoster, migraine, intracranial pathology, other causes of acute vision loss like amaurosis fugax, cluster headache, cervical spondylosis or other cervical spine disease, sinus or ear disease, TMJ pain, jaw claudication can mimic should be differentiated from TMJ pain, conjunctive tissue diseases or vasculitis. Further investigation required intended to exclude other diagnoses. So full blood count, normocytic normochromic anemia may be seen in PMR or GCA. Urea electrolytes and EGFR, liver function test, bone profile, thyroid function test, creatinine, chydins, dipstick urine analysis. Protein electrophoresis to consider benchtone proteins, rheumatoid factor to consider ANA and CCP antibodies too, and consider chest X-ray, hip or pelvis, shoulder, cervical spine X-rays. Further management of PMR. If typical symptoms or signs, management in primary care is appropriate. Start a prednisolone 15 milligrams OD. There should be a rapid response. More than 70% of the symptoms decrease in less than 1 week. If not, questions the diagnosis. ESR and CRP should return to normal in less than 4 weeks. Continue prednisolone 15 milligrams OD for 3 weeks and then decrease the dose to 12.5 milligrams OD for 3 weeks, then 10 milligrams OD for 4 to 6 weeks, and then by 1 milligram every day for 4 to 8 weeks. This is how you have to taper the steroid in polymyalgia rheumatica. Tailor the steroid regimen to the patient. Increase time at each dose may be needed. If there is a relapse of symptoms, go back to the previous higher dose. At the start of treatment, give osteoporosis prophylaxis and supply with the steroid card. Usually 1 to 2 years of treatment is needed. The need for ongoing treatment more than 2 years should prompt referral to specialist assessment. Refer for rheumatology assessment. Red flag signs are prominent systemic features, weight loss, night pain, neurological signs, require an urgent referral, symptoms of giant cell arteritis, younger patient less than 60 years, chronic onset over more than 2 months, lack of shoulder involvement, lack of inflammatory stiffness, normal or very high ESR CRP, peripheral arthritis or other features of CTD or muscle disease. Treatment dilemmas. Example, incomplete or non-response to steroids treatment required more than 2 years. These are the red flag signs and you need to refer them to rheumatology assessment. Further management of giant cell arteritis. Corticosteroids decrease the vascular complications and particularly the blindness and relieve the symptoms. 70% improvement in less than 1 week, and prescribe prednisolone 40 to 60 milligrams daily to start immediately, and a diagnosis of GCA when a diagnosis of the GCA is suspected. At the start of treatment, give osteoporosis prophylaxis and supply with a steroid card. Consider starting aspirin 75 milligrams OD. So osteoporosis prophylaxis would be with a alendronate or a bisphosphonate. Consider starting aspirin 75 milligrams OD. Refer urgently to ophthalmology or rheumatology depending on the local referral pathways for temporal arterial biopsy and ongoing management. Same day visual symptoms. If visual symptoms. Temporal artery biopsy may be negative in cases of GCA due to skip lesions. Do not withhold treatment while awaiting for biopsy, but if patient has had steroids for more than 2 weeks, and then positive biopsy is less likely. So usually whenever you're having visual symptoms, you need to send for temporal arterial biopsy on the same day. And do not withhold treatment for biopsy results. Just start the treatment if you're suspecting temporal arteritis. Vasculitis, musculoskeletal problems. So we will stop here, and tomorrow we will discuss about vasculitis from page number 500 onwards. Thank you. Have a good day.